Good afternoon and welcome to today's webinar, Eligibility and Enrollment, hosted by the Blue Shield of California Foundation. This is the third webinar of a four-part learning series on local programs for the remaining uninsured. My name is Bonnie Madura and I am working with the Foundation on this learning series. I will be your moderator for this webinar. Before we get started, I want to go through a few housekeeping items. To avoid background noise, all callers will be automatically muted throughout the webinar. If you would like to ask a question during the course of the presentation, please do so in the question window on your screen. We will do our best to address your questions at the end of the presentation. Also, just remember that today's presentation is being recorded and will be archived in the Foundation's website. Please tell your colleagues who were unable to attend so that they can still benefit from the presentation and discussion. Now I'd like to turn it over to Carolyn Wang Kong from the Blue Shield of California Foundation to say a few words. Carolyn?
Thank you, Bonnie. As Bonnie mentioned, my name is Carolyn Wang Kong and I'm a program officer with Blue Shield of California Foundation. I'd like to welcome you all to this webinar. Blue Shield of California Foundation has supported efforts to address the needs of the uninsured through several changes to the healthcare landscape, most recently the Affordable Care Act. And as many of you know, the ACA has significantly reduced the number of uninsured. However, we also know that today and in the coming years, there will still be several million Californians who remain without healthcare coverage. And projections show that up to half of these will be undocumented immigrants. In the absence of a national or statewide policy that addresses these persistent coverage and affordability challenges, California's counties have had to create individual approaches that meet the healthcare needs of the remaining uninsured. To help support these local efforts, last fall the Foundation awarded a group of grants to communities across the state in various stages of designing, planning, or implementing coverage programs for uninsured residents and undocumented immigrants. And in response to requests from this group, we've pulled together speakers who can elucidate best practices and lessons learned from their own experiences and focusing on coverage efforts. The goal of this webinar series, as Bonnie mentioned, is to highlight efforts that local communities are undertaking to design, plan for, and implement programs for the remaining uninsured. We kicked off this four-part webinar series on March 30th with a focus on developing the essential building blocks to get a program off the ground, and then continued the dialogue in April with another webinar focused on program structure and covered services. Today's webinar is designed to focus on eligibility and enrollment strategies for the remaining uninsured. However, we've tailored today's content a bit to include important strategies that are being used to reach and enroll undocumented children who are now eligible for full-scope Medi-Cal. We made this change not only to be responsive to the needs we heard from webinar attendees, but also to facilitate the timely sharing of information that can support this very important milestone. So today we're very excited to bring you speakers who will be sharing helpful information about eligibility and also sharing practical strategies to support outreach and enrollment of the remaining uninsured, including specific strategies for reaching undocumented children who are now eligible for full-scope Medi-Cal as a result of Senate Bill 75. So thank you all for your interest in supporting these issues alongside of the fantastic partners that you will hear from shortly. And we hope that you enjoy this webinar. Bonnie, back to you.
Thank you, Carolyn. I'd like to take a moment and introduce you to our speakers for this webinar. First, we have Shirley Sonamatsu, Senior Health Attorney for Western Center on Law and Poverty. After Shirley, we will hear from Rafael Gomez, Healthcare Consultant for Pacific Health Consulting Group. Then we will turn to Marmi Bermudez, Program Manager for the Health Coverage Unit of San Mateo County Health System, who will be our final speaker. With that introduction, let's get started. Shirley?
Great. Thank you very much, Bonnie, for the introduction and for having me participate in this important webinar. Just for a little background first on Western Center on Law and Poverty. We are a statewide legal services organization. We do policy advocacy together with direct legal services programs across the state and other healthcare partners to improve the policies and procedures so that low-income Californians can receive the public benefits that are available to them. So with that as a go, we can go to the first slide. And I know that one of the issues that have been addressed and that have been touched upon in various capacities in the previous webinars was about what the county indigent health programs and the mandate that counties have to provide safety net care to the remaining uninsured encompasses. So this slide is to just go over kind of the Venn diagram and the overlap between the Affordable Care Act and healthcare reform that we've all seen since 2014 and our state-based law of the Welfare and Institutions Code 17,000, which mandates that counties provide safety net care to those without insurance. And the overlap that we have is really that with the ACA, we have expanded coverage in Medi-Cal. We have our new subsidized insurance that's available through Covered California, and then the list of pre-existing conditions from private insurance. But as we know, there are those who have been left out from health reform, and those remain the persons who are have undocumented immigration status, or who have coverage where it's unaffordable to them, even with subsidies. It's unavailable to them, and in that category we're talking about persons who, if they should qualify for coverage under Covered California, but like private insurance, it has closed and open enrollment periods, and they are in a closed enrollment period and miss a special enrollment period, or simply that they are unaware of the new coverage options that are available to them. So when we look at the 17,000 program and the county health, where is it that we see people needing these services? And since I'm a lawyer, I always feel the need to go directly to the statute. And the 17,000 statute, while there are other sections of the code that touch on and discuss and bring further detail to the county mandate, it's really the 17,000 section of Welfare and Institutions Code that provides the mandate for counties to provide safety net care. And it's fairly simple language, but very open to interpretation. But what is not open to interpretation is that it is a required mandate, and that says every county shall relieve and support all incompetent, poor, and indigent persons who are lawfully resident and who are not supported or relieved by either relatives, friends, or by other state programs. Now, one of the issues that has come up often since health reform is that I would say on immigration status. And if you're participating in this webinar, then I would consider you as someone who's part of our California healthcare bubble. And within our bubble, people who are involved in healthcare eligibility and enrollment issues, I'd hazard to say everyone on this call is aware and comfortable with the fact that U.S. citizens and legal permanent residents have access to full scope Medi-Cal. So that's been the case in our state for many years, and it's common knowledge within those of us in the healthcare bubble. But even for those of us who work in the system and are very familiar with eligibility requirements, the other areas of immigration status that make it difficult for people to enroll in Medi-Cal are those who fall under either they're qualified immigrants or the separate designation of PRUCAL, persons residing under color of law. So in that area, we are looking at persons who, when we look at health reform, may be applying for coverage through Covered California. And we talked as part of health reform that one of the big changes was to create a no wrong door system, and people can apply for health coverage through Covered California or at their county offices or at their providers. But particularly for those with a different immigration status, some doors are better than others. One of the issues has been that the Covered California eligibility and enrollment, the CalHERS computer system, has not been able to accurately assess for someone's eligibility either as a deferred action status, so our DACA individuals, or necessarily for persons with PRUCAL status, the persons residing under color of law. So for those individuals, it has always been better for them to go to the county services offices for their determinations. And that is one point that I wanted to raise for the participants today. In looking at your eligibility enrollment for your county programs under 17,000 is to review who are currently participants in your county program, because there have been mistakes and issues with getting people with a PRU-call status in particular, and also for those who are DACA, to get the proper designation for full scope Medi-Cal, and they have fallen to the county programs, when really their proper designation should be in full scope Medi-Cal, where they will be, for the most part, better served with a more robust system of services that are offered and providers. So that is one suggestion, is to go and do a review of county services and see if that's a best practice, to see what your county health program has enrolled and confirm that everyone who is there actually should be there, or maybe they would actually qualify for full scope Medi-Cal. Now the 17,000 statute is one that has been around since the 1930s, and it has evolved into what are known as the medically indigent adult programs by county. And since it is a county-based program, every county has its own eligibility and requirements and criteria, and they vary. They can vary by looking at what someone's income is, their assets, age requirements, residency, and immigration status. And there is no defined list of benefits that can be created. You know, it's really at a county's discretion. So we see diversity within our state for what counties provide. And the last point here on this slide is really that if your client has received services and is low income, and they have no insurance and they're not eligible for Medi-Cal, to apply for your county for their program as soon as possible. Some counties have retroactive eligibility, but usually for a quite limited time. So it's something that I think in the push toward health reform and making sure that people who are newly qualified for Medi-Cal or can receive covered California subsidies get into those programs, that the county role in providing health care itself kind of has fallen a bit by the wayside, and we need to bring that back up. And so I'm really glad to have these webinars to do so, and that everyone here is interested in that. Now, with the varied eligibility services and eligibility requirements and services, we're going to hear later from Marmy from San Mateo, but for an example, like San Mateo has, for their eligibility criteria, free care, no-cost care for those under 138% FPL, and then cost sharing up to persons at 400% FPL. So we really are looking, though, that's just one county and its example of how it fits its criteria. One of the issues that I wanted to focus on here are I'd say the three areas of eligibility for county health programs that really can be focused on in your advocacy or within your county for looking at what those criteria are set at, and if they actually should be changed given the new environment that we have with health reform. So under the first one, all indigent persons, this is a real hot spot, because when the statute says that all counties shall provide services for all indigent, what does all really mean? Well, there is discretion when it comes to the county providing health care services, and how the county defines the indigent population is based on income and resource eligibility standards. For the most part, counties adopt all or part of the Medi-Cal resource rules. So asset tests such as that one car is exempt, the house you live in is exempt, and say $2,000 asset limit for an individual, $3,000 for a couple. Now again, that varies, but that has historically been often the case that counties will select the resource rules for Medi-Cal and have it combined. But the criteria also says that whatever criteria is used cannot leave residents without subsistence medical care. And that comes from the case law. One is under Hunt v. Superior Court, is one of the foremost cases on the duty to provide subsistence care at the county level, and that the income criteria and asset criteria must consider a person's ability to pay for the care. Hunt is the leading case on this county responsibility to establish its financial eligibility standards that take into account a person's ability to pay for and obtain necessary care. How does a county do so? A county would do so by going through what's called a BAME, named after another case, study, that assesses the cost of living requirements within that county. So it is county specific. And that once such a study is taken, looking into how much services may cost for someone in comparison to the cost of living for that county is how a county should go about determining the indigency limit for healthcare services in its program. The Alford case, Alford versus County of San Diego, was a case that struck down San Diego's flat income eligibility cap. And what I refer to in that is that it had an eligibility cap of 135% at the time in 2007. So anyone who was above 135% FPL was ineligible for the program regardless of any other circumstances, hardship exemptions. If they were $1 over, they received no care. And the Court of Appeal did strike down that standard because they did not use the cost of living subsidy and failed to consider a person's individual ability to pay all or part of their care. Now, does this county mandate under 17,000 require that every person gets an individual assessment to receive services? It does not. And it does not require that all counties implement a certain level or income level for care. The alternative for a county is to look at income levels and set sliding scale fees, income limits for free care, but still have provisions for people to receive either medical or financial hardship exemptions for them, or basically to also set a high enough income limit so that persons who receive care under that limit, if they're over the income limit, they can pay for subsistence needs, their subsistence care needs. So the income and eligibility resources is one area. The other two, and the second and third criteria I wanted to focus on then are also when it comes to legally resident. And what does legally resident mean in 17,000 context? It refers to county residency and immigration status. And immigration status is the area where that is within another part of the Welfare and Institutions Code section 17,003, which states that gives the county discretion to aid persons who are undocumented or non-residents. And the county residency issue is also one where we've seen problems in counties that have set really strict residency standards, such as a county that states that someone has to be a legal resident for up to 30 days. And we would argue that such requirements of a 30-day residency requirement would violate the 17,000 program mandate to provide care for someone who's in need. San Diego has had in the past reside and maintain a physical residence in their county, a fixed address, and I believe they have also taken that definition of legal residency out. And then when we look at the not supported and released by others, the third eligibility criteria where we see actually a big opportunity for change in the healthcare reform context is 17,000 is a residual program for counties, and it's for persons who do not qualify under any specialized aid program. With the expansion of Medi-Cal to childless adults and with subsidized insurance through Covered California, many persons are now in those programs. But what happens and how does your county look at someone's eligibility for those programs and either one, their ability to pay for subsidized coverage and their premiums in Covered California, the cost sharing, or is it an open enrollment time during a time in Covered California when they can enroll and they miss their special enrollment period? And also, of course, then if someone is undocumented and they only are eligible for Medi-Cal and restricted Medi-Cal, is that now a population that your county will look at expanding their services since it is still unavailable to them to have full scope services in Medi-Cal? So those are the three eligibility criteria that I think is very important to explore within your counties for how your county defines the medically indigent. So it would be through how is indigency defined, who is considered a resident, and what is the definition of not being supported or relieved by others. I just wanted to end this portion to say and give a plug to Western Center has an all-new healthcare eligibility guide, getting and keeping healthcare coverage for low-income Californians. And within that guide, Chapter 7 has a full discussion over and provides much more detail regarding the legal obligations under 17,000 to provide care, and goes in much more detail through these different criteria. And you can access this free guide by either just Googling Western Center Healthcare Eligibility Guide, and it will take you directly to, I think it is the first result that comes up in the search, or go to our website, wclp.org, under Advocate Resources for more information about the 17,000 obligation. Thank you very much. And that's the end for me, and I will pass it on to Raphael.
Great, thank you, Shirley. And now let's turn to Rafael Gomez to learn more about the SB 75 expansion. Rafael?
Thanks, Bonnie. Hi, everybody. As Bonnie said, I'm Rafael Gomez with the Pacific Health Consulting Group, and my colleagues, Bobby Wunsch, Tim Riley, and I have had the pleasure of working with a lot of health centers, county delivery systems, Medi-Cal managed care plans, and other safety net providers over many years. And we've also had the opportunity at times to do work that helps identify best practices like we have here. And with support from the Blue Shield of California Foundation, we have been able to publish a series of quarterly briefs since the Affordable Care Act expansion that has really been focused on community health center strategies for conducting outreach and enrollment and to get folks into coverage since the Affordable Care Act expansion. And it's really been, our briefs have really focused on trying to highlight the experiences of individual health centers. And so we've had the opportunity to speak with many health centers in the development of this brief and to tell their stories in terms of the barriers and challenges they've faced and moving folks into coverage, the strategies that they've used and what has really worked for them. Our most recent brief, which was just published yesterday and is available on our website and Blue Shield's website and should be blasted out to the Blue Shield mailing list sometime this week, is focused on what health centers have done in terms of strategies and best practices to enroll kids in the Medi-Cal as a part of the SB 75 expansion. And we spoke to a number of health centers, but we really tried to focus the case studies that we've included in our brief on health centers that are in communities that, you know, have large undocumented populations, but maybe not as many families that are known to the system as in other communities. So, you know, counties that lack large Healthy Kids programs or children in the Kaiser Child Health Program or indigent programs that have a lot of undocumented children or adults enrolled in them. The health centers that we highlight in this brief include Clinica Sierra Vista, which is a large health center serving Kern and Fresno counties. Clinicas de Salud del Pueblo, serving Riverside and Imperial County, and Vista Community Clinic, which is anchored in northern San Diego, but has also now started providing services in western Riverside and northern Orange County. And again, you know, the purpose of our brief is really to highlight some of the challenges that these health centers have faced in trying to move folks into coverage and the strategies that they've tried and the strategies that have worked for them as a part of the SB 75 expansion. So before we jump into that, it might be helpful to just briefly review a lot of information that you all probably know about the SB 75 expansion, but it's good to remind ourselves of. The SB 75 expansion, or Medi-Cal for all children, extends full scope Medi-Cal eligibility to all kids under age 19 with income up to 266% of the federal poverty level, regardless of immigration status. And that's the key shift in terms of eligibility, as you all know, is that it now allows undocumented children to move into coverage. It was effective yesterday, May 16th, and so we'll be learning a lot about how successful we are as a state in terms of getting eligible kids into coverage. The state has estimated about 170,000 eligible children statewide, and other estimates have put the number of eligible kids at up to 250,000 or even 300,000 kids in California. And I think that kind of highlights one of the challenges with this particular expansion, is that whereas we think that many of the eligible kids are known to us, we're really not sure what the total number of eligible children is and where they are and how most effectively to target them. And that's a challenge that was highlighted through some of our conversations. As I mentioned, many of the kids who have become eligible under the Medi-Cal for All Children expansion are already enrolled in some sort of coverage program and known to us in our community. So statewide, we have about 115,000 kids enrolled in restricted scope Medi-Cal, about 73,000 kids in Kaiser Child Health programs, which are available in those regions where Kaiser has a presence, and about 21,000 kids enrolled in Healthy Kids county programs. Now, not all of the kids who are in Kaiser and Healthy Kids are necessarily eligible under the SB 75 expansion, because a lot of those programs have income eligibility that goes up to 300% or even higher. But generally about 8 or 9 in 10 of kids in those programs are going to be eligible under the SB 75 expansion for Medi-Cal. The state, just as a reminder, has identified 2 big enrollment populations for SB 75. First is what they call the transition population, and that includes any child who is eligible and enrolled in restricted scope Medi-Cal prior to the May 16th implementation date. And so this is why, as I know Marnie is going to talk about, the emphasis for everyone has really been to move as many children as possible into restricted scope Medi-Cal prior to May 16th, so that they can be automatically transitioned into full scope Medi-Cal, and those that are supporting them can really focus on making sure they understand the process, that they understand the notices that they're getting from the state, and that they're able to select the medical home that they want, as they'll all be moving into managed care. The second population is the new enrollee population, and that's kids who meet the enrollment criteria, but they're not enrolled in restricted scope on May 16th. So this includes kids who are eligible but not in any program, but it also includes all of the kids who are eligible and already enrolled in the Kaiser Child Health program, the Healthy Kids County programs, and other programs such as county indigent programs in different communities. So both in Kaiser and in Healthy Kids, they've really had to make an emphasis to move those children into restricted scope Medi-Cal as well prior to the May 16th cutoff date. And looking forward, everyone who's eligible and falls into this new enrollee category will be able to complete the full scope Medi-Cal application. And these 2 populations, I think it also highlights where a lot of both the health center and other folks who are providing enrollment support have put their efforts. First into moving kids into restricted scope Medi-Cal, but then into really working with families to make sure that they understand how the transition works, all the information that they're receiving, and particularly for the Kaiser and the Healthy Kids programs, to help them so that they can keep the medical home that they have if they want to stay with it, or to make a transition into a new medical home. So as we talk about different outreach and enrollment strategies, I think it's also important to remember the community context and to remember that every county is in a different situation. And this local context really matters in terms of what we do to move folks, as strategies to move folks into coverage. First of all, it's important to take stock of the existing children's coverage programs that are available in your community. So in some communities like San Mateo, we have a number of kids who are enrolled in Healthy Kids. In other counties like Sonoma County, we have several thousand kids who are part of the Kaiser Child Health Program. In some communities, we have very generous county indigent programs. In those communities, a lot of the emphasis is really on leveraging the information that we have about folks who are already in programs and using those resources to reach out to them to provide them information. In other communities, like many that house the health centers that we spoke to, the only way that those kids are going to be known is if they're coming to your health center. And otherwise, it's a much heavier lift in terms of reaching out into the community. Other factors that are really important is what type of infrastructure and experience you have both as a health center and as a community in terms of doing outreach and enrollment and working with undocumented families. What type of expertise you have available in your system. Many communities that have really leveraged their collaborations they developed under the Affordable Care Act to do outreach and enrollment under SB 75. And also, the size and the visibility of the undocumented population in your community makes a big difference in terms of, again, what type of experience you all have working with that community, how much you know about it, and how much attention it gets in these types of efforts. So what kind of challenges have health centers seen as they've been working through the SB 75 transition? Whereas there was a lot of attention and media and public awareness and news attention to the ACA expansion, what we heard from health centers is that there has been very limited public announcements, information, and awareness in the community about the SB 75 expansion. And that's put more onus on health center providers and others who are doing enrollment and outreach work in the community to really get the word out to immigrant communities about the shift. Secondly, we talk about it a lot, but community fear about how information is going to be used, particularly in terms of immigration actions, is still a major issue. And most of the health centers that we spoke to said that within the last 6 to 9 months there had been an ICE raid in their community. You add that with the challenges I think that folks face as in terms of all the news coverage around immigration, et cetera. There's still a lot of fear in the communities that can affect their willingness to enroll in new coverage programs. Similarly, we hear it a lot, but public charge misperceptions really do persist, and families are concerned about how enrolling in Medi-Cal is going to affect either an existing application for themselves or for family members in terms of a new legal status application. And there's also a lot of misperceptions around other immigrant service providers like immigration lawyers about how enrollment in a program like Medi-Cal affects legal status applications. We also heard from health centers that even within the undocumented population, there are hard to reach populations, in particular mixed deco or other indigenous populations that don't speak Spanish, that are more isolated, and though health centers make an effort to work with them, there are significant challenges to get them into their health centers and to provide the type of support that they need. concerns about social service agency capacity, both in terms of taking on the new enrollment workload, which everyone experienced with the ACA expansion, but also in being prepared as eligibility workers to provide the right messaging and communication to immigrant families on key issues like public charge and like the use of information for immigration action. And in fact, a few health centers that we spoke with really have taken the lead on providing training to their local social service agencies and eligibility workers about the most appropriate messaging, and have taken the lead in developing materials that can be used for communication to undocumented families. And lastly, there's a lot of uncertainty about how many children are really eligible. So one of the questions we'll ask as we go forward is what kind of, how successful have we really been in terms of getting all eligible children into coverage? And we'll learn more as we go. So strategies that different health centers used. I think there are three big strategies I think that health centers highlighted in terms of that are particularly important if you're in a community that is maybe not bolstered by a large Healthy Kids program or indigent programs that have a lot of undocumented residents enrolled in them, and you don't have easy access to patients. So first, several health centers said they've led media and public service announcement campaigns. A number of health centers said that they have really engaged in some pretty intensive grassroots outreach, including door-to-door campaigns, migrant camp visits, promotora outreach. And the door-to-door campaigns have, in one instance, was a health center that has gone door-to-door in high-need communities, signed them up for coverage, met with them at libraries, met with them at their home, brought them into the health center. And at another health center, were linked with a Dolores Huerta Foundation, which was doing door-to-door campaigns in the communities they serve and provided a referral to that health center. And lastly, and very importantly, was community partnerships and collaboration, and in particular partnerships with schools, other immigrant service providers like legal aid and other service providers, and other efforts to really capitalize on the contacts and relationships that other service providers have. And lastly, and I think very importantly, is health centers rely very heavily on patient inreach. And that is, we have a lot of folks who come through our doors, are enrolled in restricted scope Medi-Cal, are uninsured, are in limited scope programs like Family Pact, and health centers have taken the opportunity of the SB 75 expansion to reach out to those families through calls, mailings, bring them in, and either get them enrolled in restricted scope Medi-Cal, now get them enrolled in full scope Medi-Cal, or take the time to talk with them about the transitions to expect, the information that they're going to be receiving from the state and from health plans. Health centers have also added more enrollment coordinators at their pediatric units or other parts of their health center, and conducted pretty big staff education campaigns as an opportunity to make sure that we get all the patients that are eligible and coming through our doors into coverage, hopefully in advance of this May 16th transition. And I know that I'm out of time, so the last thing I'd say is that the SB 75 expansion, I think also the potential for the DACA and DAPA expansion, and now a lot of counties kind of re-examining what are all the last options we have to get uninsured residents into coverage, like PRUCAL, have really prompted for a lot of communities, I think, some examination about how effectively are we serving immigrant families in our community. First, who are the trusted service providers that we can leverage to work with immigrant families? Secondly, how do we connect as immigrant service providers, both healthcare providers, legal aid service providers, promotoras, others, in providing a coordinated and integrated service for undocumented residents in terms of understanding legal options, getting into coverage that they're eligible for, and having effective referral between our services as well. What are we doing as a community to make sure that everybody who's coming in contact with immigrant families understands how to communicate effectively with them and understands all of the eligibility and enrollment rules that affect these populations. So I'll stop there. Thank you for the time, and I'll look forward to the questions.
Great. Thank you, Rafael. Before I turn it over to Marmy to tell us what's happening in San Mateo County, I'd like to remind you to submit questions in the question window on your screen. Now, let's turn it over to Marmy Bermudez. Marmy?
Thank you, Bonnie. Good afternoon, everyone, and happy second day of universal health coverage for all California kids. After Santa Clara and San Francisco County, San Mateo was the third county in California to launch its Children's Health Initiative Healthy Kids program to cover children who did not qualify for full-scope Medi-Cal and healthy families. Since January 2003, we have enrolled more than 23,000 children in our Healthy Kids program. We currently have about 3,100 Healthy Kids members, and due to the incredible funding support from the county and local funders, including 2 hospital districts and our local First 5, we never had to implement a wait list for our Healthy Kids program. To be eligible for Healthy Kids, a child must, of course, be a county resident, under 18 years old, not eligible for full-scope Medi-Cal or other health insurance, and the household income must be 400% of the federal poverty level or below. Healthy Kids members are Health Fund of San Mateo members and have comprehensive medical, dental, vision, and mental health coverage. One of the goals of the Children's Health Initiative, Healthy Kids, has been to advocate for universal health coverage for all California kids. So when SB 75 was passed in June of 2015, we were definitely ecstatic about this passage. When it was announced last June of the passage of SB 75, we immediately conducted an internal analysis and found that 3,000 of our 3,200 Healthy Kids members will be eligible for the expansion. We then started planning our outreach to these members to ensure that they are, 1, informed about the expansion and what it means, and 2, enrolled in the restricted Medi-Cal, and if they are, emphasize that they need to maintain their restricted Medi-Cal and comply with notices from Medi-Cal. If the children are not enrolled, then our CECs would help them to enroll in restricted Medi-Cal. We planned our July and August Health Coverage Coalition meetings to review and distribute outreach flyers, scripts, and FAQs about the Medi-Cal expansion to our local enrollment assisters. We also worked with our OneYap vendor, which is our enrollment system, and the Human Services Agency to see how the Healthy Kids application in OneYap can also be the restricted Medi-Cal application for new and renewing Healthy Kids members. Since the OneYap application has all of the Medi-Cal questions, including the request for tax household information or RFPHI questions. And we were successful in this, and we were able to use our Healthy Kids application as also the restricted Medi-Cal application. We also collaborated with Human Services Agency to determine how many of our Healthy Kids members have active or pending restricted Medi-Cal. We found in the fall of last year that we actually had quite a few of the eligible Healthy Kids members, over 50%, who already had active restricted Medi-Cal. Our local county work group also met to discuss updates on the transition and areas of concerns from staff. Many hours were dedicated to conducting manual research of Healthy Kids members to ensure that they have active restricted Medi-Cal. One of the surprising findings was that those Healthy Kids members who had to pay restricted Medi-Cal premiums still opted to enroll in restricted Medi-Cal even though Healthy Kids covered their emergency services. One father shared that he wanted to do this to ensure that his daughter will not have any break in coverage. It gave him peace of mind that his daughter will be transitioned on the first day of the expansion. We are very proud to announce that we were able to confirm last month that 95% of our SB 75 eligible Healthy Kids members are actually enrolled in restricted Medi-Cal, which means they will be able to transition to full scope Medi-Cal coverage this week. To achieve this, we have sent out 2 outreach letters and made at least 2 phone calls to Healthy Kids members who are still not enrolled in restricted Medi-Cal. We have about 167 members who still need to enroll in restricted Medi-Cal, and we also have some children with the Human Services Agency has recently disenrolled since they failed to comply with their renewals. We work with our Human Services Agency to ensure that they worked on the cases for the restricted Medi-Cal children who had pre-ACA 8 codes prior to May 16th. Since it was confirmed that our local SAW system would not be eligible to transition these children due to the system-related issues. We also validated and found that DHCS and our local SAW system had about the same number of restricted Medi-Cal children in our county, and that all of these children are Healthy Kids members. So we do not expect any children eligible for expansion who are not already enrolled in our Healthy Kids program. As stated earlier, we conducted trainings to both our county and certified enrollment assisters about the transition, and we work closely to make sure that our eligible Healthy Kids families are informed of the upcoming transition and its many benefits. We still have a group of children who will remain in our Healthy Kids program. Our Children's Health Initiative Oversight Coalition is in discussion about the future of our Healthy Kids program, since having an insurance program with less than 1,000 kids, let alone 500 kids, is quite expensive and likely not sustainable. For now, the groups who will remain in Healthy Kids include the undocumented children with household income between 266% to 400% FPL, our C-CHIP children. The last group of children who will remain in Healthy Kids are those documented children with household income between 322% to 400% FPL and who meet our Healthy Kids exception. This means that the exception is that the family will pay for health insurance premiums for either their employer-sponsored coverage or Covered California, and that will exceed 9.5% of their income, and that the family will also not qualify for full scope Medi-Cal share of costs. It's a very small number. We have it's less than 18 kids. Our county indigent program is called the Access and Care for Everyone program, or ACE. In the ACE program, we have about 19,000 adults enrolled in the program. Most of them are under the ACE fee waiver program, and under this program, there is no enrollment fee or co-payments. For the ACE non-fee waiver program, the participants are expected to pay a $360 enrollment, non-refundable enrollment fee plus co-payments. To be eligible for ACE, one must be a county resident, age 19 and above, no other health coverage or insurance, and not eligible for full scope Medi-Cal or Covered California. And the income must be under 200% of the federal poverty level. San Mateo County is a county organized health system, so all of our Medi-Cal beneficiaries are enrolled with the Health Fund of San Mateo, or HBSM. Like Medi-Cal and Healthy Kids, HBSM administers our ACE program. So HBSM holds the contracts with the ACE providers, specifically the non-county specialty clinic providers, and all ACE participants receive a welcome packet and an ACE coverage card from the HBSM. One of our best practices for our adult indigent program is a requirement of restricted Medi-Cal for our ACE fee waiver participants. Those are the group of ACE whose FPL is under the 138% of the federal poverty level, therefore they qualify for the restricted MAGI Medi-Cal. This requirement ensures that ER and inpatient visits are charged to Medi-Cal instead of being a net county cost. Also, we have worked it out with our Human Services Agency so that the ACE waiver application is the restricted Medi-Cal application. This ensures that applicants will only have to fill out one form. In addition, our enrollment counselors can determine final eligibility for our ACE fee waiver and therefore can tell the applicant that their application is approved on the same day of the application assistance. Lastly, we work closely with our Human Services Agency to have dedicated Medi-Cal eligibility workers who reviews and disposition these ACE fee waiver restricted Medi-Cal applications. Since these applications were all reviewed and submitted by CECs, we have close to 100% approval, and the turnaround time for these restricted Medi-Cal applications are within 24 to 48 hours. We are excited to share that we encountered great success with this. We now have 84% of our ACE waiver participants who are enrolled in restricted Medi-Cal. Our county hospital found that the charges for services billable to restricted Medi-Cal increased from $30,000 in April of 2015 to more than $600,000 in March 2016. The next steps for our county is to look at how we can work together with our county and community partners on how to further streamline our processes for the clients we serve. One area we're exploring is how we can make it work so that our AC waiver participants are only complying with one program instead of two. Another area is to see if it's possible for the state to refer those individual and families that apply in CalHERS but are found ineligible for any state programs. These are the families who might be eligible for our ACE and Healthy Kids. And with that, I'd like to end it with how we end our emails and meetings in our little San Mateo County community, SSP or Si Se Puede. Now back to Bonnie.
Thank you, Marmy. And thank you again to Rafael and Shirley for your insights and for taking the time to share your learnings with all of us today. We will now open things up for questions. As a reminder, if you would like to ask a question, please do so by typing it in the question window on your screen. Unless specified, we'll distribute each question to the most appropriate speaker to answer verbally. And for our first question, I actually would like to direct this to special guests. We have Bill Phelps and Ana Velasquez from Clinica Sierra Vista in Fresno and Kern counties to provide us with some thoughts on how children in these communities who are now eligible for full scope Medi-Cal are being identified and enrolled. Bill?
Well, thank you for inviting us to be part of this webinar. We've been working very hard in trying to get as many children into a restricted Medi-Cal in the last few months. And unlike San Mateo County and some of the other larger counties in California, our Healthy Kids program ended 4 to 5 years ago in both Kern and Fresno County. So we didn't have that group of kids that we could really reach out to as readily as they could in these other counties. However, we did a lot of inreach. We got a report from our billing department on all children under 19 years old that had either restricted Medi-Cal or were self-pay or were in the CHDP Gateway program, so that we could then have all of our certified enrollment counselors contact each household. If they couldn't reach them, then we sent them a postcard letting them know about SB 75, so we could really reach those that were already connected to our organization. We also received a grant from the California Endowment that included funding for a media campaign that was focusing on Kern County, so we're still finishing up on that, and that has resulted in a lot of families calling us for more information. And as mentioned earlier, we're working with the Dolores Huerta Foundation. They have been doing the door-to-door outreach in some of the communities in North Kern County, like the Delano area, letting families know about this new program, and that again has been generating more interest. I'm going to let Anna go ahead and give more details about what we're doing in helping reach out to these families.
Hi, this is Ana Velasquez. I also wanted to share with you guys part of what Bill was telling you. We have been working really hard here. I have 23 certified enrollment counselors. Something else that we have been doing here inside the community clinics, we have trained our staff, the people that work, the nurses, the doctors, the front reception staff, the operators. These are the people that need to know this new information, because sometimes our patients, it is the first contact that they have. So we've been pretty busy, and it's working okay. A little bit confusion with adults, because they're getting the information via media. They're coming to our health center. Okay, well, I only have emergency Medi-Cal. Can I get full scope Medi-Cal? And we're like, no, right now it's just for the children, but for the adults, it's coming.
The other thing I wanted to mention, too, is that we are part of a community-wide efforts in both Kern and Fresno County. Here in Kern County, we're part of the Community Health Initiative, which was formerly the Children's Health Initiative. And so this includes organizations like Legal Aid, the United Farm Workers Foundation, Dolores Huerta Foundation, Family Resource Centers, as well as our Department of Human Services. And so we're all working together and collaborating on community events. We had a large event back in April at one of the Hispanic marketplaces where we were able to reach quite a few people, and we're going to continue those types of outreach events in the community where we know we can reach a lot of these hard-to-reach population and make that one-on-one contact. And again, we're dealing with a lot of fear. that has to be overcome, and now there's another surge in the ICE raids. So that is, although we're not hearing anything happening locally, that word is out. That's happening here again and across many of the states in the country. And so we're going to have to keep working at reaching out to these families and helping to reassure them that they can enroll and get their kids enrolled in this program and not have to worry about that information being used against them. But it's we have a lot of fear to still overcome.
Great, thank you.
I also wanted to add, like Mermi was saying, here in Kern, we have outstanding relation with the Department of Human Services. I have eligibility workers stationed inside our clinics, so that is making our process easier. Since we have our patients, we're checking the eligibility, we're making sure they are already enrolled in emergency medical, and we talk to them about the transition process. So that's something that is really working here in Kern County.
Thank you, Bill and Anna, for those thoughts. Shirley, I have the next question is two in one maybe, and I will direct them to you. The first is regarding the eligibility criteria, the three that you outlined, and essentially all three are left up to a county to interpret and decide. The question posed is, how do I find out what my county's position is specific to how indigency is defined and whether my county is in supportive aid to undocumented and or non-residents? That's the first question. And then the second is related to CalHERS and the ability to screen for DACA.
Oh, great. Thanks, Bonnie. So I'll take the first question first, that for someone who wants to know more about their county indigent health program, there is one site that you can go to do a quick overview and just see, and I can't say that it's current, but the State Department of Healthcare Services has a website, on its website, a page for what's known as the AB 85 state realignment. And that was when the state and the counties had to do an accounting of how much money the counties and the state were exchanging over the state realignment bills from the budget 2 years ago. All that to say is that the state did a survey of the county indigent programs and what their eligibility criteria are. And so if you just Google DHCS or go to the website and Google AB 85 state realignment, there is an Excel spreadsheet available on the DHCS site for county indigent profiles. Now that was current as of 2014, so that's one way to see what county programs either have looked like, or if they haven't been updated, then that's where it's at. The other way is then just to contact your county offices directly and to ask for their policies and eligibility criteria for the medically indigent program. Some counties have such information on their websites. Others, you need to do some more digging, but that would be the best way to really get the most up-to-date information. On the second question regarding CalHERS and its ability to screen for DACA and other immigration status, that had not been part of, as I'd mentioned, as part of the CalHERS computer programming, but it is scheduled.
I think we might have lost Shirley. Okay, when she gets back, we will go back to her. In the meantime, Marmy, a couple of questions for you. One point of clarification, if you can clarify how many of the Healthy Kids enrollees already had restricted scope Medi-Cal before you started your efforts to enroll them in full scope, sort of this year. Recount that for us.
Yes, so as of late April, we have 95% of our eligible Healthy Kids members enrolled. So about 2,700 to 2,800, 2,745 to be exact.
Okay, thank you. Shirley, do we have you back?
Yes. Yes.
Okay. You started breaking up around the response around CalHERS and DACA, screening for DACA.
Oh, I'm sorry. It So what I was saying was that there is a program change scheduled to go live in July of this year, but we haven't done any user testing so we don't know how it will look or how effective it is, but it is scheduled to be changed in the CalHIS program so that it will be able to do a search of DACA status and other immigration status under proof call. Did you get that?
Great, thank you.
Okay.
Yes, thank you. So Marmy, let me turn it back to you for the second part of the question, which is any lessons that you've learned in San Mateo about training your CECs and the workforce for sort of this expanded eligibility and transitioning the kids?
I think it's the message, the best practices was to make sure that the CECs are emphasizing to the families the importance of maintaining their restricted Medi-Cal coverage, because we started this outreach track in the summer of last year. So it's ensuring for every Healthy Kids client that they assist either a new Healthy Kids members or a renewing Healthy Kids members, that they emphasize the need to maintain the restricted Medi-Cal by complying with the Human Services Agency, and also that they distribute the flyers that we've created for the families about letting them know about the transition, letting the CECs know about the different notices from the HCS, from the SAW system, when that will happen, making sure that we address any access questions that they have. Can I still keep the same provider for Healthy Kids and Medi-Cal? The answer is yes. We're fortunate in San Mateo to be a county organized health system. So, and then adding those questions to the FAQ that we've developed that we share with the CECs.
Thank you. This next question, Rafael, I will direct it to you first and then to Shirley. It's been asked a couple different ways, but it's around the public charge misperceptions. And I think folks have had experience when they've asked county human services staff about this in Medi-Cal, they've been referred to an immigration lawyer. Sometimes when they've been referred to an immigration lawyer, the advice is not to enroll in Medi-Cal coverage. Did anything surface in your interviews is sort of strategies that advocates can consider when dealing with public charge and trying to get over those misperceptions? So Rafael, I'll start with you, and then Shirley, maybe I'll turn it over to you.
Yeah, and Bonnie, I could respond, but I think Anna, has a really deep understanding of it and has a lot of experience in terms of communicating this issue to clients. She might be, I'd ask Anna if she has a couple of words of wisdom for folks on the call.
Okay, Anna, are you able to?
Yes.
Okay. Great.
Okay, well, we have seen here, this is Anna. What we have seen here in Kern, the fear of our families, the wrong messages that our community is receiving, not only for immigration lawyers, but there is a lot of people to just assist families to complete the forms. Some of them are notarios, they call them notarios. So, one of my campaigns that I have done over here is visit some of the tax offices. This is where people go and file their income taxes. And they have very little knowledge about, the programs that our families qualify. So we have done pretty much some work here in Kern and also in Fresno, because that is exactly where our families are getting the wrong message and the wrong information.
And they're also we're working with the United Farm Worker Foundation, because they're doing classes on immigration and they address public charge, and as well as our legal aid organizations are also working with some of the immigration attorneys to make sure that they have the right information. So we're really just trying to go in various directions and trying to get the accurate information out there to the community.
Bonnie, this is Shirley. Can I jump in as well?
Yes, please.
Yeah, on the public charge issue, when it comes to, I think a lot of the confusion that comes around public charge is because to receive other public benefits, such as welfare benefits, CalWorks, or food stamps, that there can be a problem or issue raised with the public charge designation. But it has been for years that does not connect. Public charge is not an issue when it comes to immigrants seeking health care services, unless the person is getting long-term care services from Medi-Cal. That is a different situation. But for other Medi-Cal services or to receive Medi-Cal eligibility, public charge should not be a barrier, but it's a common misperception.
Thank you. Marmy, I'll direct this question to you, and it comes from someone who mentioned that I know we've sort of been live now, a day and a half, and they've ran eligibility for a few children that had restricted or emergency Medi-Cal, and as of this morning, the state system still shows them with the same status, so they haven't transitioned over to full scope. Have you experienced this? I don't know if you've had a chance to check yet today and seen the same thing happen. Okay.
Sure. So what we heard from our Human Services Agency, our Medi-Cal program analyst, is that the SALS 1 system actually did not start doing the batch of checking against the BRE, the business rules engine with CalHERS until last night. And that will be about 2 to 3 days of the SALS running the batch of those that are restricted Medi-Cal in their SALS system against CalHERS. And the update in meds will likely happen in the next 2 to 3 days. And the second notice, which is the notice that will to beneficiaries stating that their restricted Medi-Cal aid code will transition to full scope aid code, will likely not be sent out until Friday, so consumers will not get that notice until next week. And then the third and final notice, which is the managed care notice, will happen the month of the transition. So before June 1st, those folks that were successful in transitioning from restricted to full scope Medi-Cal should receive that letter. And then the state also said that for those that failed to transition, they will send a list of those that are still restricted Medi-Cal on the med system. They will send that report to the local counties so they can see what happened, why it didn't transition to full scope in their SALS system. I hope that helps.
Thank you. Well, we're now out of time for today's webinar. Thank you all for a great discussion this afternoon, and a special thanks again to Shirley, Raphael, and Marmy for providing your thoughts and insights, and also to Bill and Anna for being special guests and responding to some of the questions. We encourage you to connect with one another outside of this webinar to continue learning from each other. After this webinar, we will be sending out a brief link for an evaluation survey of the webinar, as well as a link to the report that Raphael mentioned in his presentation. As a reminder, the remaining Uninsured Learning Series continues and actually will conclude at the end of next month. Our final webinar, Measuring Quality for Program Improvement, will be on June 15th from 2:30 to 3:45 p.m. I also wanted to let you know that recordings of past webinars may be found at the Foundation's website. The first 2 webinars from March 30th and from April 14th are now available on the website. The recording from this webinar will be up within the next 10 days, so please check the website for those. We also would like to post the contact information for today's speakers just for about 30 seconds. If you have any additional questions for them, please feel free to reach out to them. And again, thank you to Shirley, to Raphael, and for Marmy for participating in today's webinar. This concludes the webinar, and have a great rest of your day.